Very good afternoon. I'm Dr. Rajmanas, Assistant Professor in Plastic Department, and I welcome you all in the second series here, where we are going to share a story of a 1-year-old child that sustained electric burn, developed microstomia, and he was unable to feed himself. So we reconstructed him, correcting the microstomia, and that we reported also the first ever free flap the first ever free flap in the world. Correcting for the microstomia. So we start with I invite Dr. Nupur Jain, our senior resident, please.
Good afternoon, respected faculties and dear colleagues. I'm Dr. Nupur and I'll be presenting the first part of this clinical combined round, focusing on the primary burn management of this child who sustained electric burns involving the perioral region and went on to develop severe microstomia. So this is a patient who is 1-year-old male child weighing 7 kilograms. He had sustained electrical burns at his home address and was brought to our burns emergency by his parents. So, as per the parents, the child was playing at home when he hit the electrical wire of a refrigerator and sustained electrical burns over his oral cavity. He had a brief loss of consciousness and was taken to nearby hospital where initial resuscitation was carried out. Over the course of next 3 days, he developed progressive edema and bluish discoloration of his lips, following which he was referred to our Center for Definitive Care. At presentation, this child was playing at home when he hit at presentation, this child was conscious and alert and had a heart rate of about 150 per minute and an oxygen saturation of 98% on room air. Airway assessment revealed a patent airway with no stridor and no respiratory distress. There were no clinical signs of inhalation injury. Local examination revealed third-degree full-thickness burns involving the upper and the lower lips, the left oral commission, the filter, the left chin, and the left cheek. The injury extended up to the buccal mucosa and alveolus with the presence of a necrotic patch over the chin, as you can see in the image. Further intraoral examination was limited due to the child's age and poor coagulation. So, a diagnosis of electrically contact burn involving the functionally critical perioral and facial region was made. Although the total body surface area involved was limited, the burn was full thickness and is known to be disposed to function sequence. Given the perioral involvement, the full thickness nature of the burn, and the child's age, airway assessment and perioperative planning was critical from the outset. So, from the time of admission, the child was managed in the burns ICU for the first 5 days in conjunction with our critical care team. During this acute phase, our main goal was supportive therapy, that is to ensure the patient's airway, adequate anesthesia, as well as perioperative planning, as well as the critical care team support. So, at this point, I'd like to invite Dr. Surbi Gupta, the faculty in the Department of Anesthesia and Critical Care, to further discuss the critical care considerations for this patient.
Good afternoon, all. The ICU management of acute burns, as the case is involved in third-degree electrical burns over the face with no airway involvement. The head-to-toe examination was done, IV fluid replacement, nutrition and urine output, and vital statics and saturation monitoring was done. IV fluid replacement, we used RL DNS with 4 ml per kg person total body surface area because it was an electrical burns. And we need to restate it betterly so that patient do not land in AKI. And for pain, syrup ibugesic plus paracetamol 1.2 ml TDS was given. ABG was done to look into electrolyte disturbance, hyponatremia, which is commonly seen, metabolic acidosis, high lactate, and AKI. Complete blood count, glucose levels, and serum electrolytes were done. And transfusion was done because hemoglobin was less than 8 gram%.
Thank you, ma'am. So the other main challenge during the acute phase was feeding due to the very extensive perioral involvement with the child. Hence, child tube feeding was initiated early and was continued for the first 5 days to maintain a positive nitrogen balance as well as to protect the perioral group from contamination. I would now like to invite Ms. Harmanpreet Kaur, our nutritionist at our department as a part of the multidisciplinary team, to shed some more light on the nutritional strategies and the feed planning for this child.
Thank you, Dr. Nutur, and good afternoon, everyone present here. So, as we all know that medical nutrition is a critical part of burn management, and specifically for this patient, due to his hypermetabolic state and his age, and definitely the type of injury which involved the oral area. So we calculated the energy requirement for this patient, 1 year old, 7 kgs, percentage of burn 10%. So the energy requirement is RDA, which is 1000 kilocal, and 25%, 25 into total burn surface area, which is a formula, QRE formula for juniors. And then for the protein, we have 3 grams per kg body weight, which is suggested by most of the guidelines. And we provide, based on the calculated requirements, we formulated a high calorie and moderate protein feed, which included 150 ml of milk, 10 ml of oil, 15 grams of sugar, and 5 grams of cornstarch. We didn't include any infant formula because of osmolar load and complex protein compositions. So feed was actually total feed delivered was 900 ml per day, which was divided into multiple cycles so that it administration to the patient is according to the tolerance. The approach also allowed us to meet the energy requirement, which was the energy which was provided by this feed was 1285 kilocal per day, and protein was 22.5 grams, which is nearest to the calculated amount. So at first the patient was kept in queue for 2 hours, and then because the oral cavity was involved, clear liquids were started. And because the requirements were very high, so nasogastric tube was inserted since the very start, and milk feeds were provided for the first 3 days. Only milk feeds were provided, and then semi-solids were introduced along with the milk feeds. And after 5 days, the patient was able to take adequately orally. And now I would like hand over to Dr. Nupur for
That is the question. The calculation 10% body surface area. It's a bit much for very old.
So actually the child also had a limb involvement that was superficial, so we didn't really. So thank you. Now coming back to the burn wound, as the patient was shifted to the ward, decision was taken not to perform any early surgical reconstruction, as the involved area was relatively small and the face has an excellent vascularity. The wound was therefore allowed to heal by secondary intention. Oh, sorry. So the wound was therefore allowed to heal by secondary intention and and with the expectation of good healing. Wound management consisted of chemical debridement using terpene urea ointment, which is an enzymatic agent to soften the deep eschars. This was followed by mechanical debridement at the bedside during dressing changes. Coming to the course in hospital, the event as follows. The child was managed in our burns ICU initially during the acute phase and then subsequently shifted to the ward. The facial edema reduced, the wound condition improved, and the oral feeding was initiated again. There were no acute airway compromises and there were no evidence of wound infections during the hospital. So with an improved wound status and the child was discharged at a stable condition, the parents were advised to be on regular follow-up and a counsel regarding wound care and cleaning precautions. So the patient came back to us at a 2-week follow-up visit and the wounds had healed completely by secondary intention. However, the child had developed severe microstomia with extreme reduction in his mouth opening. So the mouth opening was reduced to about 1 fingerwidth, resulting in significant feeding difficulty as well as oral hygiene compromise. So in view of the functional compromise and the potential airway concerns in the event of a blocked nasal passage, a decision was taken to readmit this child on semi-emergency basis and he was planned for contracture release. So to summarize the primary bone management, the child received early referral. He had an ICU-based supportive care and conservative wound management was done, but which led to successful healing of the acute burn injury. However, despite normal optimal primary wound care, deep perioral burns healing by secondary intention predisposed the child to contracture formation. So at this stage, the child developed significant post-bone microstomia causing functional impairment and raising concerns regarding his feeding and airway. I would now like to hand over to my colleague Dr. Srishti, who will take you through the reconstructed journey of this child. Thank you.
Good afternoon, everyone. As Dr. Nupur has already elucidated, the child presented to us with severe microstomia at his 2-week follow-up. Our primary concerns were airway compromise, secondary to nasal obstruction, and difficulty in feeding. He was readmitted for a semi-emergency basis for an operative intervention. On detailed examination, the child had reduced mouth opening limited to only 1 finger width, and there was an immature scar around the oral aperture. Our surgical goals were to restore the oral aperture and include its function and aesthetics in restoring the oral aperture. We planned for contracture release and microstomia correction followed by reconstruction, keeping in mind a full thickness defect could be there post-debridement. The choice of tissue for reconstruction, we had various options like the skin graft, which was not a good choice because of further risk of secondary contraction and recurrence. Regional tissue was not available due to extensive scarring of adjacent areas post-burn. So we decided to proceed with the free tissue transfer. Now, what is the free tissue transfer? A free tissue transfer or a free flap reconstruction is defined as a segment of tissue, be it skin, fascia, muscle or bone, or a combination of all, that is completely detached from its original blood supply and transferred to a distant recipient site where its circulation is re-established by anastomosis of the artery and vein of the recipient vessels. In this case, the free flap that we chose was the radial artery forearm flap. It was chosen because of its thin and pliable nature, which could be conformed to the oral aperture and its reliable vascular anatomy. In this image, we can clearly see the radial artery with its vena comitatus and the cephalic vein for venous drainage. Now, once we decided to proceed with the free tissue transfer, it came with its own set of challenges, which were both surgical and anesthetic related. The surgical challenges were small vessel diameter, which was leading to technical difficulty in microvascular anastomosis. There is an increased propensity for small vessels to go into vasospasm intraoperatively and postoperatively. The tissues in children are fragile and they have limited vessel length. And there is requirement for meticulous microsurgical technique in such cases. I would now like to invite Dr. Surbi to elucidate on the anesthesia challenges in free flaps in such children.
So starting with the pre-anesthetic checkup, it is a follow-up case of electrical burns to mouth, lip, philtrum, followed by scarring, resulting in microstomia. And the case was a foot abnormal degenerativity, no ICU stay, normal development in HSD. But the only concern was anti-secreted difficult airway with restricted mouth opening. Pre-op hemoglobin being 11.4 and all other investigations within normal. So, intra-op NPO was confirmed, ENT backup was kept for tracheostomy if needed. ICU backup was taken, and with inhalation induction, fiber optic intubation was tried but failed. Direct laryngoscopy with blade 00 was done, it was failed. With direct laryngoscopy with blade 0, intubated with ET tube 3.5 and fixed at 11 centimeters. So we got the patient intubated in third attempt. Coming up to surgical thoughts.
Moving on to the surgical steps of the case, the first step was contracture release, in which an incisional release of the scar across the upper and lower lips was done. As we can see, the horizontal line depicts the incision line, and a complete excision of the scar tissue was. The next step was designing the flap.
as we call it planning in reverse, once the defect was created, a bilobe design for upper lip, lower lip, cheek and commissure was planned over the radial forearm. This is how the elevated radial artery forearm flap with its vascular pedicle lobe. In this image, we can see the bilobe design. The upper part of the flap was for the upper lip defect, the lower one was for the lower lip defect, and the lateral part was for the inset over the cheek. And we can also see the vascular pedicle containing the radial artery and the cephalic vein. This was the proposed bilobe flap design, and this was how the planned flap inset was supposed to look after the release. So a suprafacial radial artery forearm flap was raised on its pedicle, which was the radial artery, the vena comitatus, and the cephalic vein. The donor site over the forearm was resurfaced with a split thickness skin graft. This was how the microvascular anastomosis looked under the microscope. The radial artery was anastomosed with the facial artery under microscopic guidance. The vena comitatus of the radial artery were anastomosed with the facial vein, and the cephalic vein was anastomosed with the external jugular vein. We used nylon 10-0 sutures for anastomosis. Moving on to the intraoperative challenges, there was recurrent vasospasm of the recipient vessel intraoperatively, which was managed with warm saline and lidocaine. Ambient temperature of the operation theatre was maintained with radiant warmers and blowers. IV fluids were given adequately to maintain urine output and to reduce the risk of hypotension, which predisposes to flap failure. Blood loss was minimized by the use of electrocautery and tourniquet use. Coming to the anesthesia point of view, the intraoperative concerns will be illustrated by Dr. Subi.
It was a prolonged surgery, and we used crystalloids only for fluid management. 800 ml crystalloids were given, and urinary output was monitored every hourly. Blood loss was around 170 ml, with maximum allowable blood loss in 112 ml, and blood was given in post-operative after extubation. The temperature monitoring was done with warmer placed to prevent hypothermia. Patient was not extubated in view of vehicle intubation and major blood loss and was shifted to BPS ICU. In ICU, the patient was extubated and post-op we transfused the TRBC. Paracetamol TDS was given to post-op pain, and the patient was kept on nasal prongs at 2 liters per minute oxygen flow. Post-op care.
Once the patient was extubated, the post-op period remained uneventful. Flap monitoring was done as per protocol, and assessment showed satisfactory color, turgor temperature with a bright red bleed on flap on scratch testing. The patient was subsequently discharged on the 10th post-operative day. Now, during the stay in the hospital, we had to maintain the glucose levels of the patient, so he was started on NG feeds on day 2. IV fluids were given as per weight and requirement to maintain hydration, urine output, and flap perfusion. And radiant warmers were used to keep the flap warm. However, the patient presented again at 2 months with reduced mouth opening due to dehiscence of the suture line posteriorly. So, a secondary procedure in the form of commissuroplasty and flap thinning was planned. This is how the patient looked after 2 months with a well settled flap, but the mouth opening was reduced. The secondary procedure was commissuroplasty and flap debulking, and recreation of the commissure and the upper and lower lips was done. A line was drawn on both sides, equidistant from the midline till the mid-pupillary line on both sides, and a transverse incisional release was done for the flap. It was sutured posteriorly to the mucosa. This was the immediately result after commissuroplasty. The flap settled well, the mouth opening was adequate in the post-op period, there was improved oral function and aesthetics, and there was no drooling of saliva. This is the patient at his 6-month follow-up. The mouth opening has improved, the patient is having normal feeding, the lip seal is maintained. We initially planned for a palmaris longus sling, however, the orbicularis oris of the opposite side was intact, so there was no functional limitation in maintaining the lip seal. This is how the child looked when we before operating on him at 1 year of age. He is now 3 years of age. He is able to feed himself, and there is adequate mouth. Moving on to discussion. Pre-flaps in children have been a daunting challenge for even the most experienced of microsurgeons. In 1975, the youngest groin flap was done by Dr. Harry O'Moore. In 2006, a pre-LD flap was done in a 15-week-old infant by Dr. G. German. Ours is the first reported free flap reconstruction for post-electric burn microstomia in a 1-year-old child. Pre-tissue transfer has been successfully performed even in infants and very young children, and they are particularly valuable in full thickness defects such as ours and in severe burn contractions which are not amenable to any local or regional options. In 2025, a systemic review was published by John et al., which highlighted the growing number of pediatric free flaps for microstomia correction, most of which were radial forearm free flaps, and one has also used the deep inferior epigastric perforator flap. Growing evidence supports the effective and safe use of free flaps in pediatric patients, and their survival rates are comparable to those of adult populations. The only challenges of free flap in children are small diameter of vessels, such as in ours, which was less than 0.8 mm, thermoregulatory issues, limited availability of recipient vessels, especially in cases of electrical burns, need for specialized pediatric anesthesia and microsurgical expertise, growth-related considerations, including long-term flap integration and donor site morbidity. Our article has also been published in the Indian Journal of Plastic Surgery and has also been covered by the Hindustan Times. I now invite Dr. Raj Manas to please conclude the presentation.
So basically, there are two components that whenever there is a post-electric burn microstomia, it should be admitted on semi-emergency basis. That is number one. As you know that we have just started getting a lot of burn patients in last 4 to 5 years. And despite of the best treatment, most of the patients they developed the contraction. So microstomia is also kind of contraction due to the perioral burn. And free flap for the microstomia is a rare entity that we have just published. We had a lot of challenges, but I won't give a conclusion that you should keep playing with the children, a 1-year-old children with such a longer surgery of 6 hours or 7 hours. You should be very judicious. But if it is required to doing a free flap in the children, one should go ahead with the children. It is a safe and effective procedure, giving the best aesthetic and functional outcome. Thank you very much. If any question. Yes, ma'am.
Sedation and anesthesia for dressing changes in children and in adults.
Yeah, by the time patient is in ICU, this is our intensivist, he is anesthesia, trauma anesthesia. So they give the fentanyl ketamine. I think she will explain better.
Opioids are the mainstay. We use fentanyl, morphine sometimes. Yes, ma'am. Ma'am, for this patient, it was suffice. He was not tachypneic, he was not tachycardic. So we had not, and regularly they had not done lot of dressings also. Sir. Ma'am, the initial patient came with burns. At that time, dressings were done. Ma'am, fentanyl and ketamine. Ketamine. These are. Ma'am, as coolness. Second time. Ma'am, the not visibility of cords and all. It was the problem. The blade was. Yes, ma'am. Nasal intubation was done, but that time mouth opening had. It was not one finger. It was more than. It was around 2 fingers. Yes, ma'am. With the regular language. No, ma'am. We have not. Yes, ma'am.
Second time, did you keep a CMAP?
Yes, ma'am. We had kept a CMAP. Yes, ma'am. Yes, ma'am. Ma'am, blade, we have a curved blade too. Miller blades also are there, ma'am. But we had used curved blade.
Any comments, sir? Thank you.
So what is the long-term outcome expected? Is there likely to be any contracture?
Sir, it's almost 3 years that I had operated this case. Now child has grown up. He was given last month also. He is having adequate mouth opening. Another child of 5 years old, I was operated on another case. He had difficulty in the proper closure of the proper opening of the mouth, oral cavity. So I put a Parmanis longus graft for the commissure to the diadema. So that helps in the statics and statics for the competency of the.
This child is.
This child didn't require because the opposite side of auditory source was second. So we didn't require.
When it grows up, it
Yes.
requires some other surgery for aesthetics.
Aesthetic, if patient demands, then of course we can do the kind of lab cleaning and all. I think flab is the best color match compared to the skin graft and other. This reconstructive also that we are having. Yeah, we can do some kind of expander or something. Yeah, options are there.